expert, Dr. Williams.
Hi, Jackie.
Hi.
Hi, everybody else.
Thank you for joining us tonight. So we are recording this live, and it will also be available later in the EHS YouTube channel. If you have any questions and you're joining us with Zoom, please use the chat function, or we will keep an eye out on the group if you have any questions. So we're going to talk about chronic pain tonight, and I think it's important that we establish that chronic pain is different to normal hernia surgery pain. There is always going to be pain after an operation, but that is not the same as the chronic pain. Chronic pain is something that lasts longer than what is expected.
Yeah, absolutely. Chronic pain is defined as pain persisting after 3 months after the hernia surgery. Perhaps I made a small presentation. Should I give it first before we go ahead to the questions?
Yeah, please do. Let
me share my screen. Hopefully you see the presentation right now.
Yeah.
I think. Okay. My name is Willem Zwaans. I work at Maxima Medical Center in the Netherlands, in the south of the Netherlands. We also got a sub-department called SolviMax, which is a center of expertise and excellence that treats patients with chronic abdominal wall and groin pain. And we see over 1,200 new patients a year. These are my disclosure. I don't get any funding by any industry or anything. I just got a research grant from the Dutch Ministry of Health, together with my research consortium that investigates mesh-related problems. Furthermore, I'm a board member of the Dutch Hernia Society, and I co-authored the update of the guideline on groin hernia management. Now, first of all, hernia is quite a broad term. There are different kinds of hernias, including the thoracic hernias, which are really rare, and I won't discuss that in this presentation. Furthermore, there are the hiatal hernias. The ventral hernias are also quite a broad term. Those includes the incisional hernias, the umbilical ones that are around the umbilicus, the epigastric hernias that are in the upper abdomen, and the parastomal hernias when you have a stoma. And furthermore, the groin hernias are the most common type of hernia, including 20 million repairs a year worldwide, and one in 4 males will eventually get a groin hernia. So the ventral hernias are the incisional ones, and the epigastric and the umbilical ones. Now, there are different planes of the abdominal wall, and for chronic pain, it's relevant that we as the doctors consider these planes and where we did the surgery. Now, we cut a patient as a cucumber slice, and then you see this cut through the abdominal wall, and this is the ventral abdominal wall, and there are different planes here. Now you see the rectus abdominal muscle here, and a part of the lateral abdominal muscles on the sides. And where do we do surgery for the ventral ones? Now there are different planes, and the most used planes nowadays are the preperitoneal ones. So that's the one just above the abdominal cavity, not in the abdominal cavity, but it's the peritoneum on the lower side, and on the upper side, the true abdominal wall. Other planes that we mostly perform surgery nowadays are retrorectus, so behind the rectus abdominis muscle, and the retromuscular one, which is just an extension of this plane, more lateral to the lateral abdominal wall. And then the intraperitoneal one, that means that's inside the abdominal cavity, and nowadays we see less and less surgery performed over there. If we take a look at the groin, and now we cut the patient like this, as shown here in this picture, there are 2 planes in which we perform surgery, and mostly do it with a mesh augmentation. It is the posterior plane, also the preperitoneal one, as we just saw, so not inside the abdominal cavity, but just in between the peritoneum and the abdominal wall. And the second one is anteriorly, so that's in the inguinal canal. For the other ones, you always perform surgery from the abdominal cavity to above. So here you see the stomach, the diaphragm, and just underneath the diaphragm, that's where you perform the surgery, and sometimes do a mesh. But for the hiatal one, you shouldn't do that most of the times. Now you already asked the first question: what is chronic pain. Now, chronic pain is defined as pain that persists more than 3 months after the hernia repair. And the rate of chronic pain highly depends on the type of repair you previously did and the type of hernia that you did before. And if we take a look at those different hernias, the inguinal ones, when you had inguinal hernia surgery or inguinal hernia repair, the chronic pain rates vary between 6 to 11% approximately. Now for the ventral ones, this is a bit less, it's approximately 6%. And for the hiatal ones, there's really a low number of publications on chronic pain after hiatal hernia repair. Now, it's not that all those patients truly have a pain that interferes with their daily activity. Now, in 0.5 to 2%, those patients have a significant impairment in their daily activities. Those are the ones that seeks for help. The main focus of this presentation is chronic pain after inguinal hernia repair, and that is because it's the most common type of hernia. Most pain develops after inguinal hernia repair, and most research is done in this field, and also by me. Now, if you take a look at chronic pain after hernia repair, there are 3 pillars with eventual influence if chronic pain evolves. Those are the patient, those is the surgery, and that is the implant. But to my opinion, surgery has the main, absolutely major contribution to this development of chronic pain, and to a lesser extent, patient-related factors and the implant. Now, for chronic pain, there are 2 types of chronic pain. There's nerve-related or either non-nerve related, and there's quite an overlap in between. That's a combined type of pain. But for matters of clarity, I will discuss the nerve and the non-nerve related pain. Now, for the nerve-related pain, there are some causes, including entrapment into the mesh of the nerves. There are nerves running through the inguinal canal and also through the abdominal wall, which I will discuss later. And sometimes you see that those nerves get entrapped into a mesh due to scar tissue, as is shown here in this picture. Now, on the right side, you see that the mesh that is fixated at the posterior wall of the groin canal with a suture. Accidentally, they put a suture throughout the nerve, and that will eventually give a nerve-related pain, as shown here. Sometimes the nerve is injured, not on purpose, but accidentally during surgery, and you see that there's an abnormal nerve outgrowth that is called a neuroma. You see here a glass-like ball, and that leads, if this develops, then you see that this nerve continuously gives pain triggers, and the patient will have chronic pain. Other nerve-related issues, but those are more for the ventral hernia ones, include all the cutaneous branches of the intercostal nerves. Now, there are 6 intercostal nerves that are giving the sensation of the skin of the anterior abdominal wall and also the lateral abdominal wall. They all derive from the spinal cord. As you can see on the picture on the right, those run through the lateral abdominal wall in between the muscles. It gives some cutaneous branches on the lateral sides and also on the anterior side. And this is quite an overlooked cause of chronic pain, a nerve-related chronic pain, especially just after ventral hernia repair, including the epigastric and the umbilical hernia repairs. I'm sorry, I will show some pictures of surgery. Hopefully you can handle that. If not, please close your eyes from now on and do audio only. And this is an example of a cutaneous branch of the intercostal nerves. Those are penetrating through the rectus abdominis muscles. Now, for the non-nerve related pain, there are different causes, including the mesh. The mesh shrinks, and we know that approximately 20 to 30%, and that is normal. And we should always, when we perform surgery, know that. So we don't put in the mesh really tightly, so it can shrink. But sometimes this mesh shrinkage goes on, and it's excessive, and it can even shrink up to a ball, which is called a meshoma, and shown here. This is quite rare, but why this happens and with who it happens is still not clear. On the lower picture, you see that also sometimes the mesh is not completely flat when you put it in a plane, and it probably should. This is a wrinkle of the mesh, and it can also give some compression of some structures here, although this is not that that big. Furthermore, if you do a repair of the ventral hernia once, when you use the intraperitoneal plane, you put a mesh above, so that is the anterior, the abdominal wall above, and you should fixate the mesh, because otherwise it just flows there in the abdominal cavity. You can fixate it with different materials, including those deckers that you see over here, and if those deckers are placed wrongly or accidentally through a nerve, or they can also give certain types of pains. Furthermore, one of the causes that is that you see quite a lot is that the muscles of tendons are the cause of the non-nerve related pain. And one of the issues that you see a lot and discussed on in the hernia pain support group is a seroma, which is a fluid collection made by the body due to the surgery. The body always produces fluid after surgery, but sometimes this is quite excessive. And what we do is that we use certain suture techniques to reduce the amount of seroma, but if this isn't done properly, or you just got bad luck, then the seroma is quite big, and it can also compress other structures and eventually give pain. You see one of example given here, which you see quite a large seroma on the anterior abdominal wall. Now, furthermore, always recurrent hernias, you shouldn't be overlooked by the doctors. They can give pain. Infections can give pain. Less than 5% of the surgery eventually lead to infection, unfortunately, and this can also just give a non-nerve related pain. If you place a mesh intraperitoneally, you see in a majority of cases that it gives adhesions, and also these adhesions can lead to chronic pain. Now, should you use mesh, or is there no pain after repairing a hernia without mesh? Now, that is unfortunately not true. For groin hernias, it was investigated quite well, even by a Cochrane review. You see that there's no difference in chronic pain rate if you do it with or without mesh. For the ventral hernia one, you do see even a decrease in chronic pain rate after using mesh. And for the incisional ones, repair without mesh is often not an option, because the scar tissue isn't good enough to use it to suture it, and sometimes the gap can't even be closed without a mesh. Now, if you have any doubts on using this mesh or surgery, etc., please discuss this with your surgeon. If you don't trust your surgeon, please go to another one, because if you in advance don't trust your surgeon, I think you shouldn't let him or her do the surgery if you don't trust it. Now, I must say that mesh alone does not cause chronic pain, but indeed can be a contributing factor. Now, what are different treatments to use for the chronic post-operative pain? First of all, you can always use medication, including certain medication that is made for neuropathic, so the nerve-related pain. If it doesn't affect the pain at all, or it's not, it doesn't give enough pain relief, you can use a trigger point infiltration, but your surgeon or doctor will tell you that it's a local anesthetic injected at the point of maximum pain. It is particularly of interest with nerve-related pain. Other certain therapies include from the anesthesiologist slash pain specialist, which do some therapies to reset or just to destroy the nerve that is giving the problems, including cryoablation or the pulse radio frequency. And other therapies also include some alternative therapies, but also physical therapies, which can give some really good results. But again, your surgeon should discuss them with him. If this all is to no avail and you still have this chronic pain, sometimes surgery is the only good option for you after you try the conservative treatments. Now, the key messages are that chronic pain is a complex and multifactorial problem. It's not always just one cause, but it's more factors that together contribute to this problem. The chronic pain rate is not less with a non-mesh repair. And if you have any doubts or question regarding the repair or the mesh, please discuss it with your surgeon in advance. Now, chronic pain after hernia repair must be carefully evaluated by a dedicated hernia surgeon, to my opinion, and it should be treated with a tailored approach. And if you have any questions or want to give your experiences with hernia surgery, etc., I would recommend this, but you probably heard of it before.
Thank you, Willem. That was really interesting. So we do have some questions for you that some of our members have already asked. And I'm going to start with some, if that's okay. And if anybody watching has any questions too, please feel free to use the chat button and we can answer your questions there. So this member had an open umbilical hernia repair with mesh in June 2022. All went very well, but then started experiencing pain, especially with core exercises. Been back for what we thought might be an untacked mesh, but it turned out just to be a lot of scar tissue causing the pain, and the appearance on scan, if a possible return of the hernia was not seen. But the pain is pretty good with cleaning up the scar tissue. What is the scar tissue likely to cause more problems as the patient carries on recovering? If the scar tissue is causing problems now, what can they do?
Now, particularly for the inguinal hernia repairs, you see that a lot of patients, and I mean 30 to 35%, experience some type of foreign body feeling. So they feel there's something in their groin that doesn't belong there, and this can also be due to the scar tissue. But what you see in the following months, especially, you see a decrease in this rate. So after 3 months or so, the rate of this foreign body feeling has already decreased a little bit, and it will eventually decrease even more to up after 1 or 3 years or so after hernia surgery. So you can feel pain is probably isn't the right word, or more this not comfortable feeling with the scar tissue. But if it indeed she had a lot of pain directly after surgery, or it was
no, it started after surgery, it was fine, but then say we're 9 months on now, 12 months on, the pain has started.
It's probably too much. What you see is that the scar tissue will develop quite early after surgery, and you see that it loosens up a little bit after 6 weeks or so after surgery. But if she develops this pain 6 to 9 months after the repair, I think that's too much to say it's only the scar tissue, to my opinion.
Right, okay. So another question we had are, what are the early symptoms of chronic pain, and what sort of pain should be of concern?
Yeah, the symptoms, it's just pain.
Yeah,
it depends.
There's different sizes of pain, isn't there? Because
yeah,
I mean, the nerve pain, there's pain and then there's a burning.
Absolutely, it's burning, it's stabbing. A lot of people feel as if they get continuously stabbed by a knife or something. That's something a lot of people or patients who have chronic pain tell me in the outpatient clinic. Yeah, it depends on the type of pain. So the nerve-related pain is quite different from the non-nerve related pain. You, as a doctor, you can, it's not that hard to distinguish between the two of them when it's purely neuropathic, so nerve-related pain. And as you already told, it's a burning, shooting, sometimes electric shock type of pain. Yeah. Now, yeah, it depends on the type of pain. What are the symptoms and what are of major concern? If you have directly after the hernia repair, really high level of pain, just unbearable one, I think that is of concern. That isn't normal. Everybody has pain after surgery. That is indeed normal. When it's too much, so you can't even walk or get out of bed, that is not normal. And then, to my opinion, you should consult your surgeon if there isn't anything wrong.
So this man is also asking, does age play a role in chronic pain? Or can it affect anybody, any age?
Unfortunately, it does. There are certain patient-related factors that increase the chances of developing chronic pain, and one of them is indeed a younger age. So when you have a hernia repair under the age of 40, there's a higher chance on developing chronic pain. Yeah, there's nothing you can do about it. Okay. Getting older, but
we all get older.
Unfortunately, there is, yeah.
Yeah. What effect would the mesh have if you lose or gain weight? Will this cause more pain?
Probably not. What you do see is that this foreign body feeling, what I was talking about earlier, is more likely to develop when you are slimmer. But if you already have got a repair and you do get, or you do gain weight, it doesn't affect the mesh. It does, however, increases the recurrence rates. So if you gain more weight, the pressure on the abdominal wall is higher and the chances on recurrences are higher.
Okay. So Jacqueline has said, contrary to what you are saying, she's had 2 incisional hernia repairs, one without mesh and one with. Her experiences was that the mesh repair is considerably more painful. 17 years on and she's still in pain and now has a collection of autoimmune issues. Now, this is something that concerns a lot of people, doesn't it? That pain can cause the autoimmune issues as well.
Indeed, and we're doing some research
There's
about
a lot being done, isn't there, at the moment on this?
Yeah, I think we should.
And I think this is something that's for another talk on the autoimmune.
Yeah. To date, if you take a critical look at all the literature there aren't enough clues that there is no evidence that this indeed can evolve. I don't say it can be, but there isn't enough evidence. So I think what we need is to do some proper research on this before we can give or draw any firm conclusions on this. But I know it's quite a big issue for a lot of patients. And when you take a look at all the forums and also on the hernia patient support group, a lot of questions regarding this, but there isn't enough evidence or science to give any conclusions about, unfortunately. I wish I could, but I can't. Okay. There's no evidence to date.
No, and like you said, there is a lot, and I think this is for another day, another talk on the autoimmune. So. Once we've got the evidence and these later studies have been concluded.
If you are a patient with those issues and you live in the Netherlands, please say so, because I'm doing some research about it to see what is with those patients and if we can objectify those complaints, etc. But that's only for Dutch patients, unfortunately. Hopefully we can publish it in the next years when we evaluated 50 patients, but that's for later on.
Okay, so the next question. I've had a laparoscopic bilateral inguinal hernia repair last October, and it's been nothing but a bumpy ride recovery-wise. I'm still experiencing pain that comes and goes from a level of 3 to 8, with swelling on one right side only. I can be in pain for several weeks whilst only standing and walking, and then one day wake up and the pain has gone for several weeks. I feel normal. My job is physically demanding a lot of kneeling, lifting, etc. I've been back to see my surgeon and the urologist who's been dealing with chronic pain, with testicular pain and numbness around the incisional site after hernia repair. How do you cope? Now, I know this man has been struggling, and he is being treated recently for nerve pain. But he had bilateral, and it's only affecting one side.
Well, there's certain things. First of all, I think you should always rule out that there's a recurrence, because he says that he mainly got pain issues when there's more pressure, like doing exercise, etc. So that could be a recurrent, but that's probably one of the first things that is ruled out. Secondly, after a laparoscopic inguinal hernia repair, there are certain risks, nerves at risk, including the genital branch of the genital femoral nerves that is running to the scrotum. And if this nerve is giving the pain, it can be either by compression, by also a recurrent hernia, also by a neuropathy from the nerve itself, but also sometimes by scarring, or not scarring, but a little bit shrinkage of the mesh. Now, there is a difference between scrotal pain and testicular pain. For testicular pain, it's quite more difficult to treat than for the pain that is coming from the genital branch of the genital femoral nerve that is running towards the scrotum. And there's one more thing that you just, what was the third question? Numbness.
Numbness as well, yes. Now,
Yeah.
this man, he said the same as, and I feel the same with this one, that standing still in one place is one of the worst things you can do. Moving around, if you stand still in one place, it feels like everything is pulling and dragging, and then the burning starts. And this man experiences the same as I do, that he feels better being active. And I know it's hard sometimes when you're in pain to push yourself through it. But this man said to me yesterday that he feels better moving around.
But he was treated, right? Or
No, he's on a waiting list to get to see somebody from a pain clinic, and hopefully he'll be able to see somebody in October.
Okay, yeah, this sounds like a nerve problem then. And if a nerve problem, if medications are the no avail, I think you can the first thing they should do, to my opinion, that is less invasive than all the other treatments, is doing injection with a local anesthetic. And indeed, it can also be diagnostic if he has a relief of pain for like several hours, sometimes up to days, or sometimes even weeks after one injection. It's quite likely that it's indeed this nerve. It can be either diagnostic, but it can also be a treatment. If you repeat this injection for, let's say, 3 times or so, you can eventually get a total reset of this nerve and get a pain relief in approximately 1 to 5 patients or so. If not, a pain specialist can do some other treatment that is shown in my presentation, including some more invasive ones, which will also try to destroy the nerve that is giving the problems. If not, surgery can also be an option, but also has some complication. But I think, when you tell me this story, I think there's quite a good chance that this patient will get pain relief with treatments.
Yes, I think he's quite a positive person, so hopefully that helps.
That's also quite important, actually. One of the risk factors for one of the patient-related risk factors for chronic pain is also a lower optimism.
Yeah.
Question is, what do you do about it? But fortunately, it is.
Look on the bright side of life.
Yeah.
So Carol here, she's with us on Zoom. She had polyester mesh 15 by 20 centimeter repair with over 40 titanium Pro-Tacs in October 2015. Many of the Pro-Tacs are very close to her spine. The mesh is in my back to repair a hernia involving bowel and kidneys in the pectus lumbar triangle. I awoke from the op in so much pain I thought I'd gone to hell. It's attached near my diaphragm, which explains why breathing was so excruciating. My back muscles physically contort years on from the op, and I have nerve pain and muscular pain. I take paracetamol and gabapentin and other pain meds when I'm so exhausted that I need to get more than a couple of hours sleep at a time. I live in Scotland and there's no doctors or consultants know what to do. Who can help me, please? For those who listen are at a loss to know what to do with me.
I'm really sorry to hear that. Now, first of all, you got quite a rare type of hernia, a hernia of Petit. And second of all, I think they repaired it laparoscopically then, I think, with a mesh that was tacked with non-resorbable tacks. Yeah. To my opinion, it sounds like one of the tacks gives the problem. It's just too close to one of the nerves, or even penetrated to one of the nerves. And I think that also the nerves that the intercostal ones that gives also branches towards the anterior abdominal wall, but also the lateral one, and they also got branches towards your back, so the posterior side. You live in Scotland.
Yeah.
I know. Is Andrew DeBow still working there? There are some.
Andrew, I think he's up there, but there's also Demetrius, who's very good.
Yeah, there are.
And Matches also due to go to Scotland as well. So Carol, I will email you shortly after this. There are some very good pain doctors in Scotland, and we'll give you their details.
I think also for this particular case, I think there are really good treatment options for this. First of all, always start to reset the nerves with injection, but it seems like as the repair is done from inside, I think more invasive treatments.
Maybe
We'll
looking
need
at
to do
another
this.
surgery
Yeah.
then. Yeah.
Hopefully. Yeah.
Yeah,
But
but
we
I
will
will
give you some
message
names.
you after, Carol.
Yeah, we'll give you some names. There are some really good hernia surgeons over there. So.
Okay, so the thing is with hernia pain, with chronic pain, it's for many of us, it's not here all the time. It comes and goes. It's not there every minute of every day. It's a different pain and it's a unique pain. So this lady said that the pain is not unbearable. It's more like a constant soreness, something like a 2 to 3. I can walk around, sit comfortably, even cross-legged, squat down. I can sleep in all position, but the pain sort of lingers on a scale of 2 to 3 all day. So she's seen the surgeon a few times and CTs and everything all look good. What can she do?
CT only excludes a recurrent hernia and doesn't do anything else. It can give some clues on adhesions or bowel obstruction or anything like that. But to my opinion, once again, you should go to a dedicated hernia surgeon who has some understanding of chronic pain. And I think you should do a careful, patient history and do physical examination. It can already give you some clues on what are the causes and what we can give you for certain types of treatments. If you should decide for yourself if this is indeed a pain that is unbearable or continually annoying you that you can't live with, or you can, because you also see when you do nothing, when we as doctors do nothing, you see that sometimes the pain can also decrease in a certain amount of patients. Unfortunately, in some patients the pain can also increase, so you don't know which one you are. But if it's that annoying and does interfere with your daily activities to some extent, I think you should go to a dedicated hernia surgeon and take careful physical examination. See what's going on. And
I think
CT scan doesn't do anything, I think.
no. And one thing what I don't particularly like is when your doctors ask us on a scale of 1 to 10, because that pain is more different than, say, for example, for us ladies who've had childbirth, it's a different pain, and the childbirth pain is probably like a 10 compared to the hernia pain. It's all different. And I think we need to look more, like Andrew said to me recently, about how it impacts us on our daily life. If the pain is stopping us from doing something, rather than, is it, because I always feel, am I over exaggerating the pain? Do they think I'm saying it's too painful, or am I not telling them the number enough? I just don't like that pain scale. So I think it's how it affects our daily life.
There's one major concern that is there's nothing that we as doctors can do to objectify your pain. If you say you have pain, you have pain. There's nobody else.
No, nobody else
you don't have pain because you feel it.
Yeah.
And the scale on a 1 to 10, I think you should use it for the same patient. So if one patient says you got a 3 on a scale from 1 to 10, and the other patient says I got a 7, it's the same pain, which we can objectify until now. It doesn't say anything that much. It's more like if you ask it repeatedly after each treatment, it does say something. You need to evaluate it more than once. Just one time asking those pain scale doesn't say anything. I know we do use it too much. I understand what you say, Jackie. It's more like we should use it for the same patient repeatedly, and then there's something you can do about it with it.
Yes, yeah. I spoke with Andrew and Barbara about this, and maybe having a scale that is unique for hernias.
There have been some questionnaires developed over the years, particularly for ventral hernias one, and also one for the groin hernia one. I think we should. I agree with you that we should take more into account how much the patient suffers from the pain, or that once again interferes with daily activities or sexual activities or other functions, etc. That's more relevant than just that score that doesn't say anything on an individual patient when you ask it only once.
No, it's a strange one, is that one. So what about seroma pain? Because that's something that we're seeing a lot of at the moment, pain.
Yeah.
And if somebody's got a seroma, they can last for quite a few months, can't they?
Yeah, unfortunately it is. Now, for the seroma, it depends on the size of the seroma. It depends on the type of hernia and what type of mesh, etc. What you do about it. Now, if it's a small seroma, most doctors would agree with me that you don't do anything about it, because eventually the body will resolve it by itself. But it takes weeks to months for it to be resolved by the body, and it depends on the size of it. Now, if it's giving that much pain, to my opinion, you should go to the surgeon and ask to aspirate it, so to put a needle in it and to retract all the fluid from it. Now, there are two main complications. The first one is that it probably will recur, because the body, once again, when there's a cavity over there, it will fill up with fluid once more in the mostly 5 days or so after the aspiration. And the second one is an infection. And there's one thing you absolutely don't want, and that is an infected seroma, because then you need to open up the wound, open up the seroma to let everything out, and probably do some vacuum therapy or anything, or leave the wound open or put a drain in it, etc. And then you get an open wound for a longer time. So if the seroma gives you that much pain that you think it does need treatment, please go to the surgeon and ask for aspiration. And if not, please just try to live with it, because eventually the body will resolve by itself. Is it's a normal size or a small size seroma.
Okay. So we have a lady who's getting pain 10 months on, Charlie. She doesn't say how it affects her, but then again, we can try the medications. The only thing with that medication is the side effects. They can be pretty horrible to live with, those side effects. And as you said earlier, there's only really a pathway for inguinal hernias. I think something needs to be done for all the other hernias as well. A patient more understanding of the different hernias with chronic pain. Mine was an incisional hernia, and there isn't a pathway for patients like myself. For Carol and for the people with umbilical hernia, we need more understanding of that, don't we?
Yeah, absolutely. I agree. I'm not sure why there isn't that much attention on those particular hernias. I understand for the rare ones, but still. But if you do have a hernia surgeon who knows what he's talking about, he can think about the potential causes of this pain, and think about the anatomy of the abdominal wall and why there is that type of pain. And after, once again, careful physical examination, I think it gives always clues what's going on. And scans can be helpful, but aren't always excluding everything. And if you do have that much pain, it's not normal. Please don't get dismissed by your surgeon that says, no, it's normal 3 months after surgery. It's not.
No, and I think that's the hard thing, because patients, there is no measure for pain, is there? And sometimes surgeons don't want to admit that we are in pain, and what you've done to try and help us has actually made things worse in a way. I know you've repaired the hernia, so the operation was a success. But then when we go on to be in pain, it's something that's hard for you as a surgeon to accept, and not all of them want to. So I think that's the thing, the message that we have to get out is that sometimes there is chronic pain, and the hernia surgeon themselves are the best people to help treat it.
Absolutely, absolutely. And to my opinion, the one who did the surgery before should be the first one who tried to treat or help this patient. And you don't dismiss your patient, say, no, it's normal, because probably they don't know what to do or so. But please then refer to someone who does know what he's doing.
Yeah, and I think that's the thing, isn't it? There's no harm in saying, sorry, but I don't know. I can't.
Yeah, no, absolutely. Please do admit it. Yeah.
Yeah, there's no harm in that, but to just stand there and say, well, I don't know what to say, or I'm sorry, but I don't believe you, then that's the wrong attitude to have. And if that's the case, then I would be looking for another surgeon as well.
Yeah. I don't know.
Sorry.
But also before we did a lot of studies on hernias, and the main outcome was always a recurrent hernia, because for us as surgeons that was the main issue. But nowadays it's not anymore. It's more about the patient-related outcome measurements, including this pain. This is far more relevant than recurrence. Sometimes I discuss with a patient with or without mesh, and they say, I would like to do a repair without mesh, and I explain what are the complications and that they don't have any less pain with a mesh, and that I should always advise to use a mesh before, because of the reasons that I previously said. But if they truly don't want this mesh, I don't think that we should then try to convince them, and then sometimes just discuss with the patient what are the pros and cons, and if they don't want it, it's all about them. It's all about the patient satisfaction.
Yes.
And if they do get a recurrence, knowing that they didn't have that, that's one of the risks that you were taking in.
Yeah, we did the inguinal guidelines, a group of us from our support group recently with Cesare, the new guidelines. And that's one thing that came out for the patients was, for you surgeons, the risk of recurrence was the important factor, but for the patients, it was the risk of the chronic pain that was the most important factor. And they would be willing to, for the recurrence, without the risk of chronic pain.
Yeah.
Okay,
And I think that should be, because nowadays for the inguinal hernia ones, that's different, as you read the guidelines. But nowadays for the incisional ones and the ventral hernia repairs, it's still recurrence that is the absolute number one most important.
Absolutely, for those hernias, you don't want those back.
No, but it should also take into account the chronic pain and the other complications. Absolutely. Because once again, if the patient isn't happy, why should the surgeon be?
Yeah. Okay, so Natasha went in for a gallbladder removal, and she's come out with that done, but also a hernia repair that she didn't know she had. It never caused any at the same time. Yes, the surgeon repaired a hernia that he found during the operation. She hadn't known that she had it. It hadn't caused her any problems. But since she's had it done, she can't sleep on either side, and she feels like everything in her belly is moving around. It's painful. She had it done in November, so she didn't even know what type of hernia she's had. She hasn't had a follow-up either. Now, in the first place, I think the hernia probably shouldn't have been repaired.
And depending on what type of hernia and where it was, when you do a laparoscopic cholecystectomy, this is when you do a gallbladder removal, you should always place trocars, so working through the abdominal wall. And if it's, for example, around the umbilicus, and she had an umbilical hernia, what you do is after surgery, you close the abdominal wall once again, where you put the trocars in. And if it's at the same place, then you do the repair automatically. But it depends on the type of repair. I can't comment on that, I think. But it's also not normal 8 months after a gallbladder removal. I don't know if it's at the same site where she has the pain, where she had the hernia, but she doesn't even know where the hernia was, I understand.
Yeah, that's what she said. She doesn't know where the hernia was. She hasn't had any follow-up with her surgeon. She can't sleep. That's something when you're in chronic pain, sleep is hard.
Yeah, you don't have anything to do in bed, so you continuously thinking about this pain, and then most of the time, most patients then complain that it's getting worse when you lay in bed, because there's nothing you can do then. You don't have any distraction.
Right, so what are the Brian is asking now, he's looking for a mesh-free repair. He's looking at 10 to 16% of the risk of hernia repair, of chronic pain afterwards. Is that so high?
Yeah. What type of hernia is it?
Inguinal.
Yeah, that's a little bit too high. Approximately 11% is normal, depending on the type of hernia repair. I previously explained the different planes. The pre-peritoneal, so the posterior ones, repairs have less chronic pain rate, so approximately 6%, a little bit more, but 16 is a little bit high, I think. Depends on what literature we see, but
I think that's the thing, isn't it? It's always open to interpretation as the literature, isn't it?
Absolutely, yeah. There are certain things that summarize all the literature there is, and also take a look at the risk of bias of the results of those studies. Those are systematic reviews, meta-analysis, guidelines, and I previously mentioned the Cochrane reviews, which are quite reliable, I think. But for if you take a look on the internet, you can always find some type of research or article on whatever you're looking for, and I think it's always, you can always critically evaluate those papers, and that's quite hard to do if you don't have any education on that. But don't believe everything they say on the internet, and don't believe just one small paper that evaluates 2 patients with chronic pain. And so you can't draw any firm conclusions on that. It's not reliable.
No, Dr. Google's not a very good doctor.
Absolutely, but can be very convincing, I know, but it's not a very good doctor. But if you have those doubts, just come on with those papers and discuss it with your surgeon. I'm sure if it's a dedicated surgeon who is interested, then he will discuss it with you, what he thinks about and what are the pros and cons of doing it like they assume in the article, like they propose in the article.
Yeah. Okay. Now then, Carol has said she's had pins and needles in the legs. That's a bad one. I get that, Carol. So I do feel for you with that one. The pins and needles, they're not good. That's the nerve pain, isn't it?
Yeah, it sounds like the nerve pain. Yeah.
They're not pleasant at all, and there's not a lot you can do with that. What about the Botox? That's a new treatment you've been doing, isn't it?
Yeah. Now for the Botox, for before the hernia surgery, what it does, it just relaxes the abdominal wall muscles. But nowadays more and more papers are coming out that it also influences pain. To date, also it's not quite clear when to use it and what indications there are for Botox and pain. But in the upcoming years, as we use it more and more, there will be some papers on it. It's all been used for some other types of pain that is not in the abdominal wall and the groin area, but it's especially for a nerve-related pain. It could give some relief, but the papers are really scarce. Yeah,
I tried the Botox, as you know. I don't particularly like how it made me feel with the bulging, the breathlessness as well. That caused a lot of breathlessness, but I must say it did help with the burning pain.
Okay, yeah, there are some articles that explain the theory behind it, and yeah, one of the side effects indeed is that it relaxes the muscles for at least 3 months or so, 2 to 3 months, depending on where you inject it. Yeah, it potentially can be one of the new treatments for the type of pain, but I can't draw any conclusion on that, unfortunately. Hopefully you will.
So can you develop gluten intolerance or as a result of the chronic pain? Somebody said, Carol's here saying she's developed a severe gluten intolerance as well as autoimmune systems. Now we've discussed that, but celiac disease, she said, should be, as a result of the chronic pain. Do you see that often?
No, not often, but when I see patients who also have, or think about that they have some autoimmunity due to, for example, the mesh, I always send them to an immunologist to check on if there is any systemic auto-inflammatory or autoimmune disease. That should always be ruled out, always.
Yeah.
And I know it's hard to believe, but when you have a mesh and evolve autoimmune disease, it's not always due to the mesh.
No, that's the thing, isn't it? You have to understand that, is that for us patients, the pain was not there before the operation. Exactly. The only other thing different is the mesh, and sometimes we do blame the mesh. I'm guilty as anybody else of this to start with, until I learned to understand that there are sometimes things that happen in surgery, and sometimes our bodies as well, how that reacts to the mesh.
Yeah, absolutely. And I know it's human to think there has been something and afterwards something develops, so there has to be a relation between the two of them, and it's not always true. I know it's really human to think like that, but it's not always like that, especially for the autoimmune disease. But once more, I would prefer to talk about chronic pain, because everything I say about my autoimmune disease, we don't know.
No, I think as well, when you are in chronic pain, you sort of have to go through a cycle of anger. So you have to blame something. Yeah. And you have to go through these cycles where you are angry for a while. Somebody has to be at fault. This pain is there, it's taking over your life. And then you go through this, and it can last for years and years. And then you come to an acceptance stage where you don't accept it as such, but you're at peace with it at the moment. I'm at peace with my pain, and my pain now doesn't own me. I own, and I think that's important, that the pain doesn't own me. I own the pain. Absolutely. And you know, I will swear at my pain, and I'll call it all the names under the sun at times. But I won't let it control me. And I think that's part of the cycle that we have to go through as patients with this chronic pain. Yeah. And it's difficult sometimes to come to terms with that. And I think that's where a support group and talking to other people and having a good surgeon who understands that is important for us. Yeah.
I think there are some surgeons that also participate those hernia patient support group, and if any patients have some questions regarding this, you can always ask them via Jackie anonymously, or just by name. I think those are dedicated surgeons that indeed
there are I must admit, we have got some absolutely fantastic surgeons in our group, and we have some equally fantastic surgeons who aren't active members of the group and active like yourself and Hakan are. We have some more in the background, and they will always be willing to help. So if anybody does have any questions, or they have any concerns, you can either private message me. I will put my email address in the group shortly, and you can email me. It can all be done anonymously, but we will be there to help you. Yeah. There is always treatment available. Yeah.
And sometimes just nice to share the story for some patients.
Yes, just to be heard sometimes, I think is important. And for somebody to say, yeah, you are in pain and I believe you.
Yeah. Sometimes just nice to share the story for some patients. I hear myself.
Yeah. Okay, so I think that's about our time's up now, Willem. We've had a fair good chat tonight. It's been really interesting. Does anybody else have any questions before we leave?
If not, it's always possible to ask questions.
Yeah, you can ask questions at any time. And if we've missed your question, please do feel free to post in the group. Either send me a private message, or as I say, I will post everything shortly. Yeah. Okay. So thank you, everybody, for joining us tonight. This video will be available to watch live shortly in the YouTube channel on the European Hernia Society's page. And if you have anything that you want us to discuss for our next one, the next one is booked for the 6th of September, and that is going to be talking about weight loss. But if you have any suggestions for any others that you need us to talk about, please do let us know. Thank you, Willem.
Thank you, Jackie. And thank you, everybody else.
Thank you very much, everybody, for joining us. And I hope you enjoy the rest of your evening. Take care.